Man, it's a beautiful foggy day in Blue Ridge, Georgia, and if we were at Sycamore Crossing, you wouldn't be able to see us 8 feet from the camera.
It's starting to clear up out there, Dr. Whaley. It is, but yesterday, I noticed it's going to be 41 degrees, and I sent everybody a message, and you sent back kind words about this morning.
He said, "You're a wimp," is what he said. Oh. And he said, "You and Lonnie are wimps." And what did you say?
I don't remember what.
You said
you blamed it on someone else.
You said you blamed it on two people who will subsequently be on hours after we are.
Wow, there's the thing. We always said we hope you don't get captured in the war.
You think I'd tell them more information?
Yeah, exactly.
Name, rank, and serial number, right?
Folks, we are at Circuit World in Blue Ridge. A little foggy out, but it's a beautiful weekend. A beautiful weekend in front of us. Just picture perfect. Come up, hike, whatever you want to do. Dr. William Whaley, Dr. Raymond Tidman. Thank you, Georgia Cancer Specialist, affiliated with Northside Cancer Center. How are you today?
Good. Listen, the only thing we need
Why do you have that leaning up like you're ready to? You got something to say?
He's not wearing a test pattern shirt.
No,
it's so cold out there.
I'm in black. This is Friday. This is Black Friday for most people. Listen, the only important news for this winter, consistent with everything else we've been going through, is that it's very important that you wear a thick winter coat this winter so that Bill doesn't catch the flu.
Okay, that's a Fauci joke. All right, so let's get back to these questions.
Wear my coat so you don't catch the flu. Okay, let's
here we go.
Started.
Listen, I want to tell you that this today is an interesting day. The last 3 weeks we have had what I said were common problems, common things.
Right.
These are hen's teeth here, both of these today, hen's teeth. So everybody that's interested in hen's teeth, these are important because there's some real lessons in the first one.
Bill, you need to let our urban audience needs to know that hens don't have teeth.
Oh, excuse me, the urban audience. Hens don't have teeth. All right. My father is 74 years old in generally good health with mild high blood pressure. This is really the part that we're going to find interesting. He had Moderna COVID shots and had a cough. And his PCP did a chest x-ray, and a nodule was found and biopsied and was adenocarcinoma. Now, it doesn't say he didn't have COVID, but apparently he didn't. He had never smoked, and a PET scan showed lymph nodes in the armpit on the same side as the lung spot. Somehow or other, the oncologist had linked the Moderna vaccine, I guess, with the armpit. I don't know. So I'm going to show you that in a minute. The oncologist ordered a breast mammogram on him. It's a man. And he had a tiny breast cancer. The oncologist had his lung nodule removed, and it was clean with no spread or nodes. Then a mastectomy and nodes were removed. So that was 2 different operations.
Right.
The oncologist has him on tamoxifen and no chemotherapy.
But we don't have any tissue report.
Is that okay?
2 different cancer sites and no tissue.
No, we do. He got breast cancer.
Okay.
Of course, so he had a tiny breast cancer, and the lung was adeno. Remember?
Okay. So 2 different cancers.
No, it's the same cancer. It's a metastatic cancer,
Okay.
but it was so tiny in the breast you couldn't see it or feel it. Took a mammogram to find it, and he had axillary lymph nodes and stuff in his chest, and it was probably in the lymph nodes. I'm going to show this here in just a minute. Put the next. This is why I say it's hen's teeth. Put this next one up there that says about 1 in 1,000. You got that, Lonnie? 1 in 1,000 men will die will be diagnosed with breast cancer in their lifetime. Now that's hen's teeth.
It's a big,
isn't it?
well, it's
Close to hen's teeth?
I mean, it's 1/10 the rate of women.
Well, women are 1 per 8, actually.
Oh, really?
So, yeah, 1 in 8. So, but that's roughly right. It's about a 10th of that of women, or, 15th or something. So, anyway, pull it down. That's hen's teeth. Here, well, first of all, let me say, yes, at the end of the day, the oncologist is doing the right thing. All right, put that next one up there. So, this is a whole bunch of facts about breast cancer in men. One, it occurs. And so a adolescent or young adult male who has breast tenderness and a lump generally is related to their puberty and is a normal finding, particularly in teenage boys up until like 18 or 20. But once they get beyond about 23, 24, 25, then if they have an asymmetrical nipples enlarged, then you've got to look into it. If they're both enlarged, then you kind of go back to the normal gynecomastia. So this is not something that doesn't occur. With men, it almost invariably is hormonally sensitive, and they don't really have that triple negative rapid onset cancer that women do. Pull that down.
Can I pause you
Sure,
right there,
right
Bill?
there, please.
So, my experience recently is that men don't die from breast cancer, and that it's picked up despite the fact they're not looking for it. Because of their anatomy, they find it.
Yeah, it's easy.
And I'm curious about, going back to your case in just a second, how he went looking for it, or how the oncologist knew to look for it. But in any case, what you agree that men generally, we find their breast cancer and find it in a timely fashion.
That's correct. And this one here wasn't, and it isn't palpable to begin with. So this next one right here, put this up. This is the unilateral lymphadenopathy after COVID-19 vaccination, a practical management plan for radiologists. Now, you'll remember we've said here recently that they don't want to do a routine screening mammogram for at least 3 months after a COVID immunization, correct? I've said that before, because of lymph nodes on the side of the vaccination. When they do the mammogram, they'll find lymph nodes and they'll say, oh my God, they got cancer. Well, that's what we thought the first 3 or 4 months of immunizations until we got enough data. So I'm convinced that the oncologist, seeing the adenocarcinoma in the lung, he was a never smoker, and he had lymph nodes in the armpit that could have been blamed, I would think, on the vaccine, but they were hot on PET scan. Nothing shows up in the breast, gets a mammogram, and there's the cancer. So we had, a couple weeks ago, we talked about oligometastatic disease from breast cancer, where a single metastasis can be removed or treated. We also did the same thing a few weeks before that about a rectal cancer that was in the liver. So oligometastatic disease, meaning one metastasis at the time of diagnosis, those patients can be cured almost like they didn't have it. So that was aggressively treated surgically. He was made free of disease, and now he's taking tamoxifen. So let's get that next one up.
Well, wait a
there.
minute, before you go to the next one.
All right.
So is this a senior oncologist with lots of experience that was able to tease out, hey, that's noise, the vaccine's not causing the lymph nodes.
Yes,
There's something in the lung, we need to go looking for where that came from.
that's correct.
Okay.
All right, now, and that is pretty smart, that guy. But
Yeah,
anyway,
yeah.
the question was, now, if this had been colorectal cancer, remember, we would have had that patient on chemo for 6 months, right?
Yeah.
And if it had been in most other cancers, we would have had that patient on chemo for 6 months. If it was a female, she'd have been on chemo for 6 months. So this means that they did a hormone test and a recurrence profiling test that said, with hormonal therapy, the recurrence rate is so low that the toxicity of chemotherapy is not worth it. So throw that next one up there. So this is the survival rate. Got to have a survival chart for you.
yes.
Yes, every time. We got plenty of them on the next one, by the way. So this is male breast cancer with positive lymph nodes treated with hormonal therapy at the top, and that death curve there ain't a whole lot different.
It's almost
So you
flat.
say, yeah, it's about like, and that out here is 125 months. That's 10 years. So it's about like the normal death curve of people. You know, in 10 years, a lot of people going to be shot by their wife or have a car wreck or have a heart attack. So you can put that down.
Well, I mean, the take-home message from this case is, men, if you have a lump, don't ignore it. I mean, it may be 1/10 of women's breast cancer rate, but you
Right,
get cancer.
and also for the PCP is to remember that teenagers get breast lumps,
Yeah.
and young adult men in the low 20s get breast lumps because they testicles and their hormones are all going up and down like crazy. I mean, that's why they get pimples, and that's why they so want to have girlfriends so badly. So anyway, now what else did you learn?
I wasn't paying a whole lot of attention.
Oh my God! It's like that. It's like that woman in the McKaysville City Council.
I was paying attention, but I'm kind of. I don't know if I want to. I know this. Okay.
COVID shots will give you lymph nodes. You need to remember.
No,
that.
I didn't say that.
All right.
Well, no, I was paying attention, but I will say this. Okay. The question, and I don't think we've had this question before, but I remember several years back learning that men can actually get breast cancer.
We did talk about it about 3 years ago.
Has it been that long ago?
Yeah, it was at least 3 years ago.
So when I read this, and what I did learn is I did learn a lot about the possibility of men having breast cancer, and it is out there, and it is something you want to pay attention to.
Yeah, now you're talking about preventive medicine. Women are supposed to do breast self-examinations, and then I don't know how many PCPs teach men to do testicular self-examination, but that also is recommended by the American Academy of Family Practice and American College of Physicians and stuff.
And those are the young men that
yeah,
and you don't talk about. You very seldom hear, and if somebody says something about a mastectomy, you never equate that to a man. You just never think about that, but it does happen.
All right, cool.
So I did learn something.
Right.
I was paying attention, but
sort of you were. Okay, good. Now this second question, I regret having to answer this question because we have emphasized on this program for years that prostate cancer is a sensitive disease to hormonal therapy, that most men with prostate cancer don't die of it, that many can be treated by watchful waiting and not by any sort of treatment that just leave the prostate cancer sitting there. And Dr. Whaley has prostate cancer that's now 6 years old and is being observed. So that's an encouraging thing. And when you read this, you really want to cry for this family. All right, my 78-year-old brother is in bad shape from prostate cancer. So he just lays it right out there in the beginning, something ain't right. 7 months ago, he was diagnosed with Gleason cancer in lymph nodes, and his PSA was 20. Okay, we know right away now he's got an aggressive Gleason 8 tumor. His scan showed some spots in bones, and he had pain. He was started on shots and pills to block his hormones. Proper therapy for metastatic disease. There's no place for surgery or radiation there. His pain disappeared, and his PSA fell below 1. So he immediately responded to treatment. Now, every time we sit here and we talk about that, we say this patient's got a really good outlook. They will probably respond. What is he, 78? Respond to hormonal therapy for years, and his heart disease or his blood pressure or something will get him, and so he's probably not going to die of prostate cancer. I mean that's what we say all the time. This is the hen's teeth here. 4 weeks ago, the PSA jumped up to 10 in 4 weeks. So something big happened. It went from 1 to 10 in 4 weeks.
Well, it went from 20 to 1.
That's right. That means
he responded
dramatically.
And now something's happened that's gone from 1 to 10
in 4 weeks.
In
4 weeks. Now that
I want to make sure you know I'm paying attention.
Good. Getting to 20 might have taken years for all you know. Okay. And a new PET scan showed a new big mass. So there is something going on here. Frequently, that will be some other kind of cancer. If you leave the PSA out, he might have had a lymphoma or something that could come up quickly. But anyway, the oncologist had it biopsied. Well, he wanted to prove it wasn't lymphoma. And here's the crucial word, and said that this was neuroendocrine tumor that had developed. This type of tumor did not respond to hormones, and was rather resistant to chemotherapy. Now, oncologists hate to tell somebody your cancer isn't going to respond to chemotherapy.
Well, I mean, Bill, this NEC, neuroendocrine cancer, is a second cancer.
No.
It's
the prostate
cancer.
It's the prostate cancer. We'll come to that now. He said he could give chemo, but was not enthusiastic about it. And he gave us what he called end-of-life planning. Now, that's actually a billable diagnosis under the IC, whatever you call those codes. And it consists of, do you have a will? Have you given somebody durable medical power of attorney? Has somebody been given durable financial power of attorney? And have you made a decision on cardiopulmonary resuscitation or ventilator? So when an oncologist gives a family that recipe, that's the oncologist's way of saying, I'm not real sure I can help you much. Would you agree with that, Ray?
Mm-hmm.
All right. The oncologist gave us information but said, quote, it's up to the patient and his family has input. Now, that's what we've always said. If the patient is capable of making decisions, he's the one that ought to say, yes, I want to be treated, or I don't want to be treated. The oncologist gave us information. All right. Now, what would your input be? Please answer the question this week. It does not look like we have much time. Not very encouraging, is it?
Well, I'm going to say this. Let me say before you start.
All right.
Let me say before you start, okay? These guys, Dr. Whaley is going to talk to you from being the oncologist in the room sitting down with you. And I'm going to talk to you from being on the other side of going home and sitting down with your family and having that discussion.
Yeah, you've done it.
Right. So there's nothing easy about this discussion.
No.
There's nothing easy about this discussion. And I'm going to say, when you start talking about chemo, and I'm going to step out here and say, thank the good Lord, I'm going to say that. My mom survived through treatment, good treatment.
Double hit
lymphoma, but and anyone could tell you out there that's gone through this with a family, what you go through in chemo treatments, it's excruciating, it's hard, I'm going to say it's hard to watch, but it's hard on the individual.
How old was your mother?
Late 70s, okay, mid 70s.
Okay, this man's 78.
78, but so you have to have quality of life discussion. Do you want to see mom or dad go through this? Now, I'm going to say this, and I'm going to turn it over to you. If the doctor, when we sit down, was very hopeful, not that they're not, but very hopeful, and at no time did we hear an option was end-of-life planning.
Right, because she had a high chance of responding.
A high chance of responding.
Going through stuff to get there, like training for a marathon.
Right. Now, I will tell you this, when we had the discussion that said, what if we get done? And that's when he said, when we get done, if this doesn't work, I'll say it that way, and we don't get the results we're looking for, then you guys are going to have to make some decisions. There are some other things through bone marrow transplant and stuff like that. But that's what, so I guess I'm going to leave it here. If I was sitting down and the doctor actually went, after sitting through this myself with my brother and sisters and family, if my doctor was saying that this is an option, you just have to think about the last days. How am I putting this? I'm trying to be ginger about it.
The quality versus the
quality
quantity.
of last days of
versus
spending with that loved one. That's I'll leave it there.
Okay. All right. So,
I don't know if I've helped.
No, you did good. You did a good job. All right, put up that first one.
Because you're right. I don't know. I
Okay.
mean, when you said it just makes you want to cry, I don't.
All right, I guarantee you that nobody out there has ever heard of neuroendocrine prostate cancer. This says neuroendocrine prostate cancer, spectrum, diagnosis, and treatment. Pull that down. This next one we got here is the staging of prostate cancer. So this guy on the far right-hand side had positive lymph nodes at the time of his diagnosis, and it was in bone. So he had stage 4 disease at the outset. That's not generally the way prostate cancer is diagnosed, but you remember about 4 weeks ago, the man was in his 90s, was driving a tractor, and then went bad in 4 weeks. And I said, give that man the hormones. He's going to turn around. He'll go back on the tractor. Well, that's not this situation. Pull that one down. If you look at this, put that up there now. This next one here is the Gleason Score. The top survivals of Gleason 5 and 6, Gleason 6 and 6, that's what I've got, is the same life expectancy almost as the age. This bottom one down here is Gleason 8. And so Gleason 8, regardless of whether it can be surgically removed or whatever, that higher grade, meaning it's more advanced, even with the surgery and everything else, has a much poorer survival curve. So now you look at your survival curve. Pull that one down. So when you get to this next one, put that survival curve up. This is that big old thing going out there, the survival curve of Gleason 8 with and without hormonal therapy. So number one, that thing you saw a minute ago was, you can pull that down now, it's too confusing. But that first one was Gleason 8 survives like this, Gleason 7 like this, and Gleason 6 way up there, and Gleason 10 way down there. So this one he just pulled down shows if you take Gleason 8 and give them hormones, those curves are still pretty close together. Hormonal treatment does not dramatically improve the long-term outcome of Gleason 8. Pull that one
Bill,
down.
you might take a minute to talk about the Gleason scoring or the histology there.
All right. Gleason 8 is given in two parts. I had a couple of slides on that, but the colors weren't too good. The Gleason score is 2 scores. How aggressive this thing is in the majority of the biopsy and what the highest score is. So 3 plus 3 means that everything is relatively low grade. 3 plus 4 means some of it's a little more aggressive, but it's the minority. 4 plus 3 would mean the majority is 4 and a little of it's 3. So when you get to 7, you got more aggressive. 8 is aggressive, and all the thing is aggressive, and then above that it's more
And
high.
this is
higher.
the pathologist looking at
Pathologist,
the specimen in the microscope.
And in the microscope, yeah, it can't be done by blood tests. Okay, we're going to put this next one up, and I'm going to bring it back to you. We had others that I could show, but I wanted to save time for the news here. So, what's that thing?
Algorithm. Yes.
All right. So, I'm going to just run through this quickly because I think this is because I'm going to take it to the place here. So, this begins up here. This is the initial treatment of metastatic and non-metastatic castrate-resistant prostate cancer. That means it's recurred after the hormones, which this did. Okay, got it?
Right.
Now, if you just go through this, thing, did he respond? You get to this point right here and says, does he have a good performance status or not? And the answer is no. This guy is sick as a dog and at home. And when you get to there, it says palliative care. So that the
That's referral to
hospice. So bring that, you can take that down now. So here, what Ray said is this is a new tumor. So if you have a high-grade prostate cancer, I just want you to imagine that you've got a garbage can full of white marbles, and you put 6 black marbles in there. Well, you dig your hands in there, and you're going to just see white marbles under the microscope. When you give the hormonal therapy and it responds, every white marble's gone, and those 6 black marbles are down at the bottom. And if those marbles are in that cancer and they're neuroendocrine, they're going to grow because the rest of that tumor is gone, and they can grow in weeks, and the survival is never more than a year, regardless of what you do. Chemotherapy, it's not going to respond to hormones, doesn't respond well to chemotherapy. So this guy went south so fast in 4 weeks that even if you gave him chemotherapy is going to take a few weeks to work. I'm not sure it would do him any good. So my input to you here is, if he has gotten to the point where his plans have all been made, you've followed his advice and gotten the durable powers of attorney, I'd call the family and friends and come together and visit with him. But he is the man that's going to say, I want to take a treatment or I want to go on hospice. And so my advice to you is, do what the doctor told you, make all those plans, gather the family together and let them talk to him, but then say, Dad, brother, what do you want to do?
I want to hit on that, but I need to learn something here myself. Neuroendocrine tumors occur in several different other kinds of cancer later on.
Well, first of all, you have neuroendocrine tumors of the lung. And those people with generally, well, if they have the symptoms, they wheeze and they get rashes. Neuroendocrine tumors of the GI tract, and those, which are common. We've talked about neuroendocrine colon tumors, small bowel tumors,
And
everything. They are low grade.
I always think of them as separate tumors.
They're low grade.
But it's not an extension of the colon cancer. It's the colon cancer patient got an NEC.
Got a neuroendocrine tumor now.
But in urology, we're saying the prostate cancer, when it morphs or when the rare thing occurs and you get a neuroendocrine tumor, you're calling them the same.
Yes. Let's go back now.
Okay.
Let's go back to this. Remember that small cell cancer of the lung, which the average survival is 6 weeks to 6 months from diagnosis unless they respond to chemotherapy, is a neuroendocrine differentiated tumor, and prostate cancer has a biologic behavior like small cell lung cancer and is rapidly progressive and rapidly fatal.
So that terminology is coming from the initial cell line
Yes.
that the tumor came from.
That's correct.
Whereas I'm thinking of NEC as mostly the presentation of the findings, the blood pressure changes, the flushing.
Or rash or wheezing
right.
or whatever. Yeah.
Okay.
All right, let me ask just a really quick questions that pretty much are yes or no. According to this, the way this question's framed, the brother is getting good care.
Great care.
Great care. Okay, because I'm thinking these are the things that we were thinking through when not we were making the decision, my mom's making the decision. Second, there's no time for another opinion.
No.
Here, no time for another opinion. And the only thing I will say is, chemo, you get very sick. You watch the individual get very sick.
Not necessarily.
Not necessarily, but
Not anymore. I mean, in the old days, yes.
All right,
but not so
all
much
right,
now.
not necessarily. But all right, that's what happened with my mother.
Double hit though is a different thing. So you're
Okay.
talking about breast cancer, colon cancer.
All right,
no.
and
So-
and you know,
So let me spring off that.
okay.
From a primary care perspective, well, first of all, I could tell you when your oncologist starts talking about being referred to end-of-life hospice issues, that's big.
Okay.
Because he's saying, I really don't have much to offer you here. When I find a patient that I think has cancer and I'm going to send them to the oncologist, I save the CA word, and I'll talk about the C word or something like this all through the conversation until the very last thing that we talk about going out the door, and then that follows with what I'm going to tell you now. When patients hear the C word, the cancer word, everything goes black. You know, they're not,
Right,
most
exactly.
likely they're not going to hear anything else for the rest of the time. So I'll at that point say, well, we're going to get you to someone who's going to get to the bottom of this right away, and they're going to give you some idea what your options are and what your chances are and how it's going to go. So but you've heard the big word, and it's going to make you think a lot. Well, one of the things I want you to think about is ain't none of us getting out of this alive. We're not. So now you're getting hit in the head with, well, okay, well, I guess I need to start facing that. Now, maybe I'm going to survive, maybe I'm not. But I should start making sure that my life's where it's supposed to be and that I've got everything in order that I shouldn't have in order. Because we need to be doing that anyway.
Right. I agree with that. That's,
So
It
I mean,
could be a car
I'll
wreck.
yeah, I could be getting in the car and driving to the oncologist office. But the point is that that's usually a good moment when you can sort of say, all right, let's start getting the housekeeping stuff in order also.
Let me go back. I'm going to capitalize on that just a minute. We discussed this years ago with breast cancer. So when you have made a diagnosis of cancer of the breast and you are explaining this to the patient, several things I told you before, if this is done with an exact script and the doctor gives the information to the patient retains about 35%. If it's given to the patient by the nurse, they keep 65%. Why? It's the exact same script, because the patient focuses on the doctor and thinks the doctor can be able to help me and quits thinking about the cancer. Now, if you let that person have their sister or another person in the room, then the retention from that is the same between the doctor and the nurse, because the other person there got the info when the patient themselves was, as he says, focusing on the C word. So that's the end of that.
Thank you, Georgia Cancer Specialist affiliated with Northside Cancer Center, for our segment every week, News of the Day, medical news of the day.
All right, because this is a Wade Tidman question. What's that thing right there say?
COVID detecting dogs.
Pilot first airport
Wait, I had to
program.
get back.
COVID detecting dogs. I'm going to shut up. Dr. Tidman's
Well, I
the
have,
dog
I have a
man.
personal experience with this, and Lee's probably going to kill me for saying this, but
Look, let me give you the first thing first.
Lee, I have
All
no
right,
control.
Okay, here's the story. In Miami, there's a study going on at American Airlines, has a huge base, and they have a dog that for 2 months sniffed the masks of all American Airlines employees as they went through security. That dog was 98% able to detect which ones would have a positive test, even if they weren't sick. 98%. So after the first month, they got a second dog. So now they got 2 dogs that can go 24 hours a day, and they've extended the program another couple of months. Now, I also said, Ray, we're talking in the green room, there are dogs that can detect recurrent ovarian cancer in the 90s. Now he's going to the airport.
well, I mean, dogs are incredible critters, so I love my dog. But one time, Lee and I were returning from a trip overseas, and we were sitting there waiting to go through customs. And, it's a big, long line. You're kind of annoying and everything. And this little beagle comes over and sits down next to Lee's purse. And this lady with a badge on and everything comes up to her and she says, "Ma'am, do you have any food or fruit or anything from overseas?" And Lee goes, No, of course not. She says, "I need to look in your bag." So she picks up the bag, and there is an apple that Lee had picked up off the hotel, when you go out the exit.
Yeah, exactly.
And it's put it, maybe I'll be hungry later on, and put it in her purse. And so
she
I'm like
forgot.
looking at this apple and looking at the dog, looking at the lady with the badge, and I'm like, "Can we just throw this apple away?" She goes, No. We need to go through all of your luggage now.
Yeah.
So don't be forgetful when you go through.
Don't have time, but they took my pineapple. That's all I'll say. It always bothered me. It's 30 some years
You
now.
need counseling over there.
They took my pineapple. I'll never forgive them
talk.
for that.
All right.
Go
But
ahead.
now, if a dog smells you and they start jumping on your
All right,
mask and everything, that's bad.
We
That's real
have
bad.
we've got to hit the COVID for a minute here, because there's things that this is going to show you that we've been discussing it for a long time. Now, remember how many deaths have occurred in Fannin County from COVID? Do you remember what it was last week?
74, 76.
Yeah, somewhere.
92. How big a jump is that in a week?
That's a big jump.
That's a jump of over 15 in 1 week. Now, let's go to these 2 charts. Now, you've seen these charts, so this is last week's chart, and this is this week's chart. What was the positive rate last week?
You got to give me a big screen.
18.2. Remember, it had been
Right.
1 in January. It got up to 20 a couple of weeks ago.
And that's 7.
That it was 18.2. This is this week, and it is 9.6. It has fallen 50%.
Right.
Okay, now come over here, because this is the part that is so important that nobody pays any attention to. If you look at the total number of new cases last week, when it was 18 point something, there were 6 deaths that week. This week, it's 9.5, and there are how many deaths this week? That went too small on me here, didn't it? How many deaths this week? There are, that was 45, there are 107. So double the number of deaths this week when the positive tests are half. Hospitalizations are double, ICU admissions are double when the positive number is fallen by 50%. Why?
I don't know.
Because the disease is
Burning
lagging
out.
by
Yeah.
2 weeks when your
death
positive
curve
test
lags.
comes up.
Yeah.
The death curve's out here from the positive test last week and week before last.
Okay.
All right, now we've had a big debate, and I want the green room people, I want you to listen to this. There is a lot of stuff on the internet that the CDC has finally admitted that many of the deaths from COVID were from heart disease and people in hospice and people that had other diseases. Okay?
Overdiagnosed
Okay, now.
death rate.
Oh, yeah, okay, now the question is, there's 660,000 excess deaths in this year. So, when the guy has heart disease, chronic renal failure, chronic lung disease, and lives in a nursing home, now that's the guy who gets COVID and dies, and the CDC says the death is COVID related, but the death certificate says he died of pneumonia or he died of kidney failure. The people that are trying to elicit that he didn't die of COVID, he died of COVID. But the thing that made him die of COVID was his poor comorbid condition. So, if your comorbid condition is obesity or age, and not that you have heart failure or something else, then that is a COVID death that nobody's going to argue with.
Now,
They're going to say that patient was
Let me untangle
obese.
that because that's very complicated,
It
what
is.
you just said. This is pre-COVID, okay? Doctors, after they attend a patient who dies, are responsible for doing the death certificate. There is a lot of judgment that goes into that.
Yeah.
It is not precise. Now, if somebody has a certain kind of cancer and you've been treating that kind of cancer,
Everybody
and they die,
dies of heart failure and cardiac
their heart
arrest.
quits working. So cardiac
Yeah.
arrest is not a fair diagnosis.
Yes, can't
okay.
use it.
But if I'm treating somebody that has heart failure and renal failure, and I'm doing everything I can to
And they
mitigate
die,
those two
they
problems,
die of multi-organ failure.
multi-organ failure,
with
but I could put,
pneumonia.
yeah, I could put renal failure as the chief diagnosis or heart failure and be equally right.
But if
It's-
they were in
it's-
the hospital with pneumonia and all of it fell together, they would have put pneumonia because that's what got them in the hospital, even though it's renal failure, liver failure, and heart failure that made them die
But
from
I
pneumonia.
guess where I'm going with this, it's no conspiracy, but there is a way that they are pushing doctors to diagnose things that is manipulating to a small degree the number of COVID deaths. And I know that very intuitively because if you look at the, quote, death burden of COVID in the United States versus the rest of the world, we supposedly have 15% of the COVID deaths in the world in America. Well, what does that tell me? It tells me that they're not counting things the same as we're counting things over there.
Overseas, that's
okay,
right.
overseas, just not counting it the same. It's no conspiracy. It's no nothing.
Right,
It's just
exactly.
that statistic means nothing. That we have 15
All right,
cents of the
now
death
here's
rate.
another statistic. The death rate in the state of Alabama exceeds the birth rate. That doesn't exist. It doesn't exist. The reason it does is because there is excess death now from COVID and the COVID variant, period. And the birth rate in Alabama went up like everybody else's did because people during the COVID epidemic, when they were at home, had more opportunity to have relations and the birth rates go up. But still the death rate went up such that the death rate was higher than the birth rate. That doesn't occur. People are born a little bit more than have excess deaths.
All right, so
That's why the population always rises. The
All right.
population doesn't
let
fall.
me say this.
All right.
I sit between two people I really trust, and I'm going to say that candidly. I trust both of you And when you tell me things, I listen. So, but this is not coming with a but. But it's not the two of you, okay, that I have any concern with.
All right.
It's not the information the two of you ever bring here. But what has happened, and I've stayed in tune with it in the last 2 years, I am almost to a trust nothing.
I think that's fine. I think that's fair.
Data, this week it's this. I'm almost there for what they have done politically, manipulated, and things that have been changed and whatever.
I think that's a good thing for the audience to hear, because there is an overt manipulation of information going on in this country around this position.
Because people would say to me, well, you're just an uneducated, you're on there uneducated, watching those YouTube videos and this and that. Well, I don't claim to be real educated, but I've sit here since March, right? From the very beginning.
That was February of 2020.
Right, that we have, you guys have studied this, you followed it. I've followed this from all sides. So I'm just going to say, I'm at the point where I don't get into the argument, because there's an argument on whether COVID is real. There's an argument on whether the vaccine is real. I don't go down that road and get in that argument. But the trust factor, not there with me. Now, I'm going to switch to this. Ron DeSantis puts a new head of the Department of Health of Florida in, and he kindly says, you know what?
Get healthy.
We're not going to go down opinion. We're not going to, I don't want to quote him, but, so you were in class with somebody that's positive. How do you feel? You feel good? No, get back to class.
Yeah. Well, that's my closing statement.
That's
get back to life.
That's been our closing
right?
Get back to life. Get normal. Get this fear out of your life. Get it absolutely out of your life. And number two, and this is not our sponsor saying this and not any other academic saying this, there are treatments available. Identify a physician. If you care to go down that line, identify a physician and get those treatments early. Do not go to the vet store. Do not go anywhere else and try to get those treatments. You get a doctor's care on that. But there are excellent treatments out there if you get it early.
So
the best one is to go get the antibody.
If you can get to it.
Yeah,
absolutely.
I had trouble yesterday getting an antibody for a doctor,
yeah.
But I got it. It took me about 10 hours, but we got it.
This new health director of health.
I saw him. He's an impressive guy.
Impressive guy from UCLA. He's not,
Well, nobody from UCLA can be right, though. I mean, they have people out there. I told you all last week about David Goldie from UCLA.
That's where this all went wrong.
All right, California. You ain't talking to me about no California guy being no expert. See how I let my grammar.
I was almost there.
I let my grammar come down to the community level here.
What do you have this morning?
That's it. Get on with your life.
I want you to get on with your life.
Get on with your life. That means high school football. Get on with your life. Come up here and get on with your life. It's going to be a beautiful weekend, right?
Yeah, you're going to have fog. It's going to be 43 in the morning, but it'll be 70 by about noon, 1 o'clock.
You have to get to work, and you have to call Lee and apologize for telling that
And you
story.
have to go get a nice, good winter coat.
All right. All-star political panel right after this,
Thank you, Northside Hospital.
Yes.
Affiliated with, Georgia Cancer Specialists affiliated with the Northside Cancer Center.
Absolutely.